right. Thanks, Angie, and thanks, Doctor's Data, as always. I love partnering with you guys and delivering some good education. We can never have too much education and implementation in our practices. And this one is one of my favorite lectures and topics because hormones are the harmony of the body, right? And when I started my clinic 25 years ago, I named it the Harmony Healing Center because I've always been into hormones, and I did my naturopathic endocrinology certification at the National Institute of Endocrine Research. So hormones have always been top of my practice model and the way I look at patients. And there's been kind of this disturbing trend in functional medicine where HRT is becoming just so popular, and for good reason. Our endocrine systems are totally messed up. There's no doubt. I think there's an ICD-10 code for that. Totally messed up endocrine system. But the way it's done, it's not really very standardized. And I see time and time again in my practice, almost every day, certainly every week, a couple of patients walk in being overtreated ultimately. Some are undertreated, but the vast majority of patients are being overtreated with HRT or inappropriately treated. So I wanted to give just a piece here of why that is. And the big reason why that is because practitioners I see aren't using the right blood testing for the type of HRT that's happening. So we'll get into that. That's kind of the main crux of today. We're going to be going into the difference between saliva, urine, and blood testing, which one is the most applicable to your choice of HRT or the presentation of the patient. And we'll get into some case studies too. We'll get into a good case study because those are always good learning tools. So as Angie said, buckle up. We've got a lot of slides to cover. You have a copy of these slides. If not, you will get a link to it also in the follow-up emails. This will be recorded and it'll be on the Doctor's Data website for you to also review. So again, thank you, Doctor's Data, for having me. Standard disclaimer. We're going to talk about the Doctor's Data hormone testing menu. There's a lot to choose from. We'll explain why I think morning cortisol is probably the most clinically significant, even though we'll talk about the cortisol awakening response and the HPA axis. I'll describe the gut gonadal axis, which is a really exciting area of research that's been expanding in the last few years, and its implications for fertility, menopause, andropause, you name it. One of the things that I really focus on in my practice is fertility. Fertility rates continue to decline, and it is an area where it's not just about getting pregnant, it's about having healthy babies. And that's something that we all can be a part of in terms of just discussing it with our patients and even if they're grandparents, and talking to your patients who are grandparents to talk to their kids about, hey, what you do pre-conception and during gestation is probably the single greatest impact you'll ever have on the health and well-being of your children. So I have fertility guides and things like that. And I'll be mentioning this throughout, but if you want to go to I have two websites, Dr. Brandon Lundell, and you can download some free guides, or nutritionalpathology.com. And that's where all of my educational courses. So Dr. Brandon Lundell is my clinic side, and then nutritionalpathology.com is the educational side. But we've got a lot of great resources for doctors and patients. We'll help you differentiate between blood, urine, and saliva, as I said. And also, I want to just throw in there another disturbing trend based on the research that's not really research-based is giving women so much testosterone, specifically postmenopausal women. This is a disturbing trend. I'm not against testosterone therapy in postmenopausal women, but again, people aren't doing the right testing to monitor what the tissue levels are. And so most women are being vastly, vastly overtreated. And the literature is not as convincing as Glasser and some other authors have postulated that testosterone therapy is so good for breast cancer prevention. So what we're going to do a critical evaluation of that claim. First, I always outline a hormone talk with the context of what functional endocrinology is. We always forget the journey of the hormone. It's actually an 8 to 9 stage framework of, we get stuck in endocrinology of what's in the blood, right? And that's only giving us one of those stages. That's only evaluating what's being produced short term, but we're actually talking about the brain, the HPAG axis or the HPATG axis is the brain communicating with the gonads and with the endocrine glands. Then it's transportation, and then it's pre-receptor, post-receptor, translation, and then hormone and detoxification. All of those stages need to be addressed and assessed if you are interfering or interjecting any hormone replacement or hormone therapies, even if it's a glandular or even if it's just an herb or let alone HRT. So we'll talk about methodology. We'll talk about the hormone testing from doctor's data, and we'll go into that case study, as I said. So let's begin. This is the same outline twice. Okay, functional endocrinology, the journey of the hormone. I'll go through this pretty quickly because if any of you have listened to me before, as I said, I always like to create the context of what what true endocrinology is. So from production to elimination. So I'll go through this quickly, but hormones are the communication system of the body. As I said, the Harmony Healing Center, which means you don't assess it in isolation. You should never just assess the hormones and create a therapy based on a blood test or even a saliva test or urine test. Remember, hormones are neuroendocrine active steroids. We want to look at the mitochondria. We want to look at the immune system. We want to look at the GI system, and we want to look at why. Good doctors know what to do. Great doctors know why. We have to understand why hormones are out of balance in order to truly treat it from a functional medicine lens, right? Just giving an end-stage hormone is actually not functional medicine. It is not, because it's not treating the underlying issue. It's treating the symptom. So HRT, in its essence, is only treating a symptom for the most part. Now, the argument is that, well, supraphysiological hormones in greater than normal amounts has benefits, and that is partially true and partially not true, which we'll just touch upon today. So functional endocrinology does not simply replace hormones. It repairs and rejuvenates. It's truly restorative medicine. Then, if you do need HRT, it should always be the lowest possible effective dose. And that is what we're going to focus on most today, because when people are doing HRT, if you don't use the right testing methodology, you cannot dose appropriately. And that's what's happening in 99% of clinics and doctors' offices out there. So endocrine dysfunction is rising. There's no doubt, because of all the endocrine disruptors, because of the dysbiosis, because of the chemicals, pharmaceuticals, nutrient depletion, stress, chronic inflammation, you name it. These are the drivers of endocrine dysfunction, not, missing a pellet in my butt, right? That's not driving the endocrine problems. It's like, darn it, I was born without testosterone pellets in my butt. So therefore that's the only treatment I have available to me. That's not true. So, and then again, when bioidenticals are used, the lowest amount. So production and secretion is where most doctors stop, most practitioners stop, just looking at blood levels. Remember, steroid hormones are made in the mitochondria and the smooth endoplasmic reticulum. So the number one cause and ultimately therapeutic endpoint for endocrine problems is oxidative stress. Oxidative stress is the number one contributor to all types of hormone problems, whether it's fertility, or infertility, whether it's PCOS or, which they're changing the name now, and PMOOS, I think it's called now, polyendocrine metabolic ovarian syndrome, and or disorder, and or whether it's andropause, menopause, you name it. Oxidative stress is at the center of most of those dysfunctions. Even if someone is born with hypogonadism, which is more and more and more common, especially males, being more affected by the estrogenic molecules and chemicals in our environment. That's why autism is 5-to-1 male to female. So mitochondrial integrity is non-negotiable in any hormone. So if you are just giving HRT out there, I'm hoping to inspire you to expand your horizons, do more, address the issue, address the cause of what's happening, and not just the end stage problem or symptom. So, and we'll go through some protocols here. Look at the gut microbiome. It's very much an overlooked endocrine organ. It's not just about the estrobolome or the androbolome. It is the lipopolysaccharides and the inflammation and the signals that disrupt the mitochondria as well. So low hormone is rarely, but sometimes, a primary glandular failure. It's almost always a downstream signal of these mitochondrial GI inflammatory and oxidative stresses. So we have transport, pre-receptor, receptor, all of these things have to be looked at. Sexual hormone binding globulin and cortisol binding globulin, thyroid binding globulin, also not very looked at. If you want to know more about functional endocrinology, please go to nutritionalpathology.com. I have several different courses on that. And I have a whole certification course as well. I do the certification course once a year. It's a 100-hour certification course. And that's this year already started, but it's going to start a new one in November. So you can get on the wait list and secure your spot now. So go to nutritionalpathology.com, because I don't want to spend a lot of time on this, but it's so important to understand every single stage that the hormone goes through, because that's ultimately what's causing endocrine problems, everything from infertility to cancers. So we'll talk about, or we want to assess pre-receptor activation, for instance, 5-deadenase enzymes, 5-alpha reductase, things like that, receptor presence and density. And this is one of the things that is very much misunderstood. When you have supraphysiological hormones, whether endogenous or exogenous, the receptors will down regulate. Okay, let me repeat that, because if you get nothing from this lecture but that, and you follow that train of thought, you will be a better practitioner. Whether exogenous or endogenous, when there's an excess amount of hormones or a supraphysiological amount of hormones, the receptors will always down regulate. This is the whole principle of insulin resistance as well. And very much insulin resistance parallels endocrine problems, because everything that affects the insulin receptor also affects the steroid hormone receptors. Now, insulin receptors are more cell surface, and steroid hormone receptors are intracellular, more susceptible to oxidative stress. But all of the same things: leaky gut, right? What causes insulin resistance? It's not just Cheetos and chocolate cake, right? Although those aren't helpful. It's it is doing gut dysbiosis and inflammation, nutrient deficiencies, chromium, vitamin C, all of that destroys the cell surface and the receptors. Please remember, this needs to be used along with, even if you do it along with HRT, you'll need less HRT. The patient will need less HRT, and that's always a good thing, at least for the patient. Maybe not for the pharmaceutical companies, but and then you have post-receptor signaling, phosphorylation cascades. If they can't make ATP, the hormone isn't going to do anything. So what do people do? They just add more hormones or peptides, whatever it is, more hormones, more peptides. I'm not getting the symptom relief I want. So just keep adding that and forgetting that it's the cells that are being dysfunctional first and not the hormone. So remember, a normal serum hormone level says nothing about how it's being transported, binding, pre-receptor, conversion, receptor sensitivity, post-receptor, all of that. So the thing about saliva that we'll talk about is it does capture the free transport independent fraction. And then the HuMap captures the pre-receptor and post-receptor metabolism of those hormones together they expose what serum labs cannot see. And one of the pre questions that one of you asked was, I'm confused because these authorities who have written books on hormones say, oh yeah, just look at serum levels and that is the most appropriate. And what I'm going to give to you today is the proof that that is not the case for most cases, for most people. So again, this is just a hepatic phase 1, phase 2. That's appropriate for assessing your HuMap testing. Laboratory testing for restorative endocrinology. What do? We test the downstream functional markers as well, not just hormone levels, whether it's blood, saliva, or urine. We also want to test the downstream. For example, MCV and cholesterol are great hypothyroid cues, right? Elevated MCV and elevated cholesterol, that almost a good indicator of whether the thyroid is functioning well or not. Serum electrolytes, clinical pearl number 2 for today. A low serum sodium in your CMP is one of the greatest indicators of adrenal dysfunction. Why? Because we all know about the cortisol shunt or the pregnenolone steal that happens. And so when the adrenals are under stress, whether acute or chronic, what the enzymes get shunted towards making cortisol and stealing pregnenolone. So that means that there's not enough left over to make things like mineralocorticoids and aldosterone. So what happens? Aldosterone and mineralocorticoids are there to keep electrolytes in the body. So what happens is a lot of people say, well, I'm drinking water, even with electrolytes, and it's going right through me. That's because there isn't enough aldosterone to keep the electrolytes in the system. So the kidneys are literally dumping the electrolytes. That's why in all adrenal support systems, electrolytes becomes very, very important in your treatments. So drinking enough water is important, but always having electrolytes with the water. And there's many of them out there. Some are better than others. I can give you what I use. If you can email me for any questions. You can email, go to drbrandonlundell.com or nutritionalpathology.com and submit a question there, and we'll get back to you within 24 to 48 hours. I always answer questions that people send. So if you send me a question, I will answer it. That's my commitment when I do these seminars. I also like to add organic acids to check the downstream metabolites. How is alpha hydroxybutyrate, kynurenate, methylmalonic acid, amino acids, all of that is giving you a more functional status of the cell, and really important. And we'll get to that in the case study. Okay, genetic SNPs too, and just always a quick caveat with genetic SNPs. Please, I'll make a few pleas in this lecture. One is don't just rely on blood hormones, but the second one is never give supplementation advice based on just a genetic SNP test. That is bad medicine. It is not standardized. It is not scientific. Yes, it gives you an idea of what could be happening, but you always have to do the phenotypical test, the phenotype test. The genotype tests are great. What SNPs do you have? And sure, it can give you a clue as to pay more attention to your vitamin D or MTHFR, but never give someone a supplement plan based on that. You are going to hurt them because what you ultimately have to do is run the test to see what are their vitamin D levels and what are their SAMe levels and those kinds of things. You can't just base it off of a CMT SNP test. Okay, all right, off this soapbox on that one. So the clinical problem, normal serum lab values don't match the patient experience. And also when you're on HRT, you can't rely on serum lab values. So patient on HRT, let me get rid of that here. Can't see. Okay. Patient is on HRT and presents with, continued symptoms, anxiety, palpitations, breast tenderness, brain fog, all the things that lead us to considering HRT in the first place. And maybe they felt better at first, but then the symptoms reappear or new ones emerge. Usually you run the labs, the serum labs, and they come back normal or within accepted treatment ranges, yet symptoms persist or even worsen. What is the conventional response? I see this time and time again is to keep dosing higher, switch products, dismiss the patient, put them on an SSRI, you name it. That is not what is the science is saying is the appropriate thing to do. So the problem isn't the patient. The problem is the testing that is being done. Remember, fat soluble hormones, sex hormones are fat soluble, okay, which means they exist in the blood very short period of time. They get bound not only to sex hormone binding globulin, but they get bound to the red blood cell. And guess what? When you test serum levels do not look at red blood cell bound hormones or white blood cell bound hormones. They hitch a ride, and this was discovered 20 years ago, even 30 years ago, that fat soluble hormones do hitch a ride on the cell membranes of the red blood cell and the white blood cell, which are really the only cells that should be in the blood. And those have phospholipid bilayers, which means they do attract and hold the hormones. And it's a very large reservoir for serum hormones that do not show up in traditional serum testing. So the other thing is transdermal creams, gels, pellet implants. They bypass the first pass hepatic metabolism. They go straight into the bloodstream, but they also go straight into the lymphatic system. And so really only about 1 to 3% of transdermal gets into the bloodstream, and it's usually only there for a half hour to an hour, and it's back out into the tissues. So that means that blood is not at all where those hormones go, whether you're doing intramuscular pellets, whether you're doing sublingual, whether you're doing creams, topicals, anything parenteral, blood levels do not reflect tissue levels, period. Again, if you get nothing out of today, then understanding that statement, blood levels when giving parenteral steroid hormones do not and cannot reflect tissue levels. Okay. And study after study shows it. Also, my practice shows it. I can give you hundreds. I'm only going to give you one, but I can give you hundreds of cases where patients come in. They're on HRT. We run the saliva and urine tests and the blood test at the same time. Blood levels look fine. Serum levels look fine, but the saliva and hormone tests are 20, 30, sometimes 100 times higher than even therapeutic levels. And we wonder why patients aren't getting better. We wonder why there's still a great risk with HRT. There's just no way around it. Anyone who says there's not a risk just doesn't understand physiology. How can you add 10, 20, 30 times more of a hormone and not increase the risk for hormone-dependent cancers? There's no way that doesn't exist. You have to do it with the functional medicine principles. Decrease the oxidative stress and increase hepatic biotransformation and elimination. So, so saliva testing measures the unbound, and urine testing adds the methylation and conjugation layer. So what did the patient actually do with those hormones? So the three methods at a glance, again, saliva measures the biologically active unbound hormone fraction at the tissue level. And even when there a few of the studies that looks at, especially the more adipose tissue you have, when we look at adipose tissue levels, even the saliva is under reporting the levels that get stuck into the fat tissue, because remember, hormones are fat soluble. They are lipophilic. And so they will stay in the tissues for months, even years. I have seen testosterone levels be high over a year after discontinuing intramuscular testosterone shots. So urine reveals, again, the methylation. Blood is useful for general assessment of production. Not saying it's not useful. I run blood serum levels, especially if someone is not on HRT, but it still does not give you always the best idea of what the tissues are being exposed to. But of course, blood is sometimes more convenient. It's just one time. You can test more in blood. You can do the sex hormone binding globulin, total testosterone, lipid, CBC, all of the things that you want to test for in your blood. But it misses the membrane bound and adipose stored pool. You cannot distinguish therapeutic from supraphysiological dosing. Doesn't reveal the estrogen metabolites for like 4-hydroxy or 16-hydroxy or methoxy. Cannot capture the cortisol awakening response and the circadian rhythm. That's the other clinical pearl. All of those practitioners out there that are doing sex hormone HRT without addressing the adrenals, that's like trying to treat a tree that isn't healthy by just treating the root or just treating the branch and the trunk, okay, and not addressing the root. It's the root that might be an issue. The adrenals are 50% of all hormone problems, sex hormone problems. So, it's cheap, it's widely available. So it does have its uses. So let's talk about the methodology. The 4 hormone compartments, as I said, plasma, only 1 to 3% of body hormones is in the plasma. 1 to 3%. We all learned that passing the boards, and then I think we forgot that when we started, HRT in our practices. How can you base a good treatment plan only assessing 1 to 3% of the system that you are addressing? So not a really good way to do that. The membrane bound fraction could be up to 50% in the blood, up to 50%. And then, of course, the adipose, lymphatic, intracellular, extracellular stored. That's probably the largest store, actually. So, and then the conjugated metabolites. So each compartment answers a different clinical question, and you don't want to confuse them. As I said, this is just a little bit more for your reference. Why does serum fail for parenteral hormone replacement? The other thing that I don't like about parenteral, pellets are a little bit better, obviously, than intramuscular. That's my least favorite, because you're getting this massive dose of hormone, and then you cause receptor shutdown. And then after 2 or 3 days, whatever your cycle is, you're at your nadir, and the cells become even more deficient than they were before the HRT because of the receptor shutdown. So those are my least favorite ways of doing it. Transdermal creams are better if you're going to do parenteral, but it causes more of that fat soluble depot effect. Sex hormone binding globulin, as I said, masks that active fraction, but even the Endocrine Society explicitly does not recommend serum monitoring for parenteral testosterone, yet it remains the dominant practice in mainstream clinics, so HRT clinics. So patients are routinely told their hormones are fine, they're at their good levels, or they keep getting dosed up. So, and I'll just show one of that. Saliva, in a case study, saliva captures the free unbound hormone, as we said. It is more tissue equilibrated levels. Saliva reflects the diffusion between the bloodstream and the salivary gland and the extracellular matrix. So You can also get multiple time points in a single day. As we will see, it's the curve in the adrenal and the HPA axis saliva test that is more telling than just the level sometimes. I also always add, most of the time, add a melatonin profile. It's interesting. People often ask me, why is the pituitary and pineal gland so dysfunctional? Because they are. Well, interestingly, and the adrenal glands, interestingly enough, other than the heart, but more than the brain in general, there is more vitamin C and glutathione in the pineal gland and pituitary gland and adrenal gland than any other tissue in the body. Why is that? Because it's so metabolically active and it needs to stay protected from oxidative stress. So when somebody doesn't have enough antioxidants, which most people don't unless they're supplementing and eating really well and all of that, then their pituitary, pineal, and adrenal glands are going to suffer. So clinical pearl number, whatever, 5 or 6, oxidative stress, vitamin C. This is the cause of why pituitary glands and pineal glands and adrenal glands fail. I read once in an old journal that you can prevent scurvy, which is a vitamin C related deficiency, as we know, by eating citrus and things, and that's why they call the British sailors limeys, because they would, they would do that with. So adrenal glands, you can prevent scurvy, and that's why they call them limeys, right? But you can't treat scurvy, and they used to treat scurvy by giving people the adrenal glands. So that's why the vitamin C is so important, and it's not as glamorous as NAD or peptides, but it's still one of the most critical things that doctors miss. So okay. And saliva is the only validated medium for monitoring parenteral HRT. So this is just some studies here. The free hormone hypothesis. It's been around since 1981, and it's been proven time and time again. So you can look at these studies here. Transport of protein-bound hormones into tissues. So this one I really like because it showed that lipophilic steroids partition rapidly into red blood cell membranes in adipose tissue, creating a body burden reservoir invisible to plasma-only assays. So again, this has been around forever, but it's for some reason just being missed in the clinical practice of things. Steroids in saliva for endocrine evaluations, the landmark endocrine reviews. It validated salivary measurement for cortisol, testosterone, progesterone, estradiol, DHEA, all of that. So it's not the only thing to use. We still want to use blood levels to monitor production, but or non-parenteral. But I always add the saliva in if I'm going to do blood as well. So this is just another saliva equals the free serum cortisol. And it's interesting, it's a markedly non-linear relationship. So salivary cortisol rises rapidly even while serum levels plateau. So saliva is the more sensitive marker of your biologically active cortisol excess or deficiencies. So it can pick up on stress way quicker. If cortisol levels are too high in the morning, that's almost always a stressed out system. And time and time again, you run a cortisol level in the blood that's only going to catch your Cushing's, or your Addison's type of diseases. So progesterone cream, again, saliva, not serum. In this study, at the same time points of the two groups, they all got 64 milligrams of topical progesterone, and they looked at saliva and blood at the same time. Serum progesterone did not rise during the first 3 hours after application, and even urinary metabolites were unchanged. But salivary was five-fold higher than the blood. So definitive evidence that salivary measurement is really the only valid monitoring method for progesterone cream. One of the questions was, when when someone is on HRT, what is the methodology? So of when to test and all of that. If they're premenopausal, we always test day 19 and 20. If they're on hormones, my rule, this is just mine, I want to know what levels are actually in their system. And I want to know what that HRT is doing. So if they're going to start a salivary hormone test at 8 o'clock in the morning, they can take their progesterone if they're doing it at night. They can take it the day before. I want them to take it the day before because I want to see what's happening to those hormones in both the saliva and the urine with the HuMap. So have them take it, but I don't have them take it the day of because the levels are just going to be so high that that it can interfere with some of the other assays. So I don't have them take their hormones the day of the test. Plus, if they're doing creams and they touch the saliva tube, and there's just too many potential errors there. So I don't have them do it the day of testing, and hormone testing should only take a day. So, okay. And we already talked about the three media. So let me talk about testosterone therapy for women for just a second before we kind of jump into the case study here. Because there's just so much, misconception. There's no doubt testosterone plays an important role in female sexual health pre and post menopause. Its use in women, especially for enhancing libido, is very common, but also surrounded by misconception. And remember, the main cause of low testosterone in postmenopausal women is all the same that we discussed: the oxidative stress, the adrenals not functioning well, and virtually all women have postmenopausal women have relatively low levels of testosterone. So when you increase testosterone, yes, you can block some estrogen effects, but at what cost? And that's what we're going to talk about. So the Glasser testosterone hypothesis, which is what a lot of testosterone therapy is based on for women, the claim was that testosterone pellets reduce breast cancer risk, based on some retrospective and some prospective studies widely circulated in the testosterone community. Glasser and Dimitrakakis did those studies, and it's driven massive growth in pellets for women. And the claim is that it's breast cancer protective. So I'm not giving you an anti-testosterone position. It's really a critique of the unjustified high dose use, not just pellets, but intramuscular too. So, and especially premenopausal women, there is no physiological basis for a postmenopausal woman to have levels that are 3 to 4, even 5 times higher than an 18-year-old male. That is going to do some potential damage. And it's not functional medicine. Even if it does have some breast cancer protective aspect to it, which is still up in the air, it's still controversial. At what cost, right? You get, androgenism in females, you get hirsutism, and deepening of the voice. You get all of these potential problems, and there's evidence that shows it actually increases the risk for ovarian cancers and, of course, metabolic dysfunction because testosterone can drive insulin resistance. So the underlying studies here, I'm going to give you a quick critique. So this is the study, and the first one, and 8 invasive breast cancer cases were observed versus the SEER predicted rates. And yeah, there's no doubt that the people who took testosterone had lower rates of breast cancer. But here's the key. They always give testosterone in these studies with an aromatase inhibitor. So recent studies have shown that it's actually not the testosterone, but it's the aromatase inhibitor that reduced breast cancer incidence. So let me repeat that. It is actually not necessarily the testosterone that provides the primary breast cancer protective benefits. It is the aromatase inhibitor, and that is proven. So many studies that look now at testosterone and aromatase versus just aromatase versus just testosterone, the testosterone and aromatase and the aromatase, identical breast cancer protection. The one with just testosterone, not so much. Statistically significant less breast cancer protection. So that this is proof that testosterone is not the main driver of breast cancer protection. So that claim needs to be refuted that it's just testosterone. There's a couple of other fatal flaws, you might say. Sample bias, the patients self-selected into the group are always, mostly younger, healthier, more affluent. There was no adjusting and accounting for that. No matched control groups and no biomarker monitoring, no free hormone measurements, no estrogen metabolites, no methylation status. So what effect it was actually having on the cells was invisible to the data. So you can't conclude that testosterone was the main driver. And in fact, that's kind of been refuted. And of course, this study is very controversial, but you can't throw the baby out with the bathwater. Just because, the WHI initiative was flawed, it doesn't mean that, that all of the data is irrelevant. It is not. It shows in many ways a clear harm and a clear risk for all HRT, no matter what form. But some better than others, and that's when you tease out the data. Some is better than others. So what actually reduces breast cancer risk from a functional medicine standpoint, right? If there's a better way to do it than giving someone a very biologically active exogenous hormone, which is really not the safest way to go, no matter how you look at it. There's so many other interventions that in the literature, when you stack it, for power of evidence, that they're actually better. Adequate vitamin D status from pretty much your whole life. So having low vitamin D most of your life and then correcting it when you're in your 60s doesn't give you the same benefit as having good levels throughout your lifetime. Robust melatonin production is also very oncoprotective. That's why we test it. And that's why so many people are low in their melatonin, is because of the oxidative stress to the pineal, pituitary, and adrenal glands or endocrine glands. Healthy methylation status is also, as we know, one of the most breast cancer protective. If I had to just choose one clinical intervention for breast cancer protection, the literature clearly points to methylation. Why? Because methylation silences the oncogenes. That is critical. If you don't have enough methyl groups on the genes, those cancer genes are more likely to be read, especially for women with familial breast cancer risk. So cruciferous vegetables and diindolylmethane, keeping a healthy liver, that would probably be my second endpoint. And then the gut, gonadal, would be my third endpoint. So all of these things, you're going to get better bang for your buck than giving someone expensive and risky testosterone. So body composition has a higher correlation than hormone status to breast cancer. Sleep, stress, alcohol, all of that stuff is really important. So here's just some studies here. We don't need to go into these. These are ones that you've probably seen. If not, they're in your notes. This is one that I do like, though. Melatonin and breast cancer risk. Decades of research is a good review article. Melatonin itself inhibits estrogen receptor signaling, so it is a SERM. Curcumin are SERMs. Resveratrol are SERMs. Quercetin are SERMs. Fish oils are SERMs. There's so many other selective estrogen receptor modulators, or we can call them ERMs, because they're not just selective for the breast or the uterine tissue, but they allow those receptors to function optimally. So just great evidence there. Just the one that I use the most for doctor's data testing is the comprehensive plus saliva plus melatonin. That gives you the estrogen fractionation. I do it in all of my premenopausal women, and I only do it in my postmenopausal women if they are on estriol, in addition to, or biased, in addition to, progesterone or something. If they're just on a progesterone and estradiol, then I reserve looking at estriol spillover, and estrone spillover. I look at the HuMap. Okay, so I'll get to when I do the HuMap. All premenopausal women with high breast cancer risk, and anyone on HRT is usually when I do the HuMap test. So yeah, perimenopausal workup, fatigue. This is looking at your adrenals. It's looking at, you can add a cortisol awakening response to that as well if you want. It's got the 6 steroid hormones, plus your melatonin if you want. And it's a quick turnaround time. It's usually back once the lab gets it within 7 to 10 days. This is the HuMap, which we'll get to in the case study because I want to get to that. And the HuMap reveals 2-hydroxy, 4-hydroxy, 16-hydroxys, the 2-methoxy. I think they aren't doing the 4-methoxy right now, because it's just such a low level that it's hard to detect that's clinically relevant. But you're looking at true methylation status there, and detoxification. So now, when do I run the basic hormone profile? The basic hormone profile is just a single cortisol in the morning, plus your testosterone, estrogen, estradiol, DHEA, and progesterone. So that's just when you want kind of a quick look at when somebody is transitioning off or even transitioning on. You don't have to do the whole hormone test. But I always look at that adrenal gland, morning cortisol. Morning cortisol is one of the most important because that's what shows you what the capacity is of the adrenal glands, to restore and to repair. So the morning cortisol will start to increase quicker than the rest of the day and the rest of the curve because it's able to restore and repair and regranulate at night if the patient is getting enough sleep, if there's enough melatonin. Melatonin triggers adrenal regranulation and repair. That's another reason why melatonin is so important, if they're low in it, especially. But even if their melatonin levels are normal, I do like to dose melatonin super physiologically sometimes because it's such a potent stimulator of the HPA-TG axis repair. Okay, and it's a lower cost. So we talked about estrogen carcinogenesis, and the 4 and 16 ratios. So just some studies here showing what the HuMap looks at. Okay. So the decision tree, a new functional medicine patient, absolutely the comprehensive plus saliva and melatonin. That's your baseline for a premenopausal and a male as well. Males get the comprehensive saliva. The comprehensive plus is your premenopausal, or anyone on HRT. So once you've established the patient on any kind of HRT, whether herbal or functional medicine or actual HRT, then you can use your basic hormone profile, especially if it's parenteral. If there's a family history of breast cancer, then I'll add the HuMap. We'll add the HuMap at about a month or two after they're on HRT, or if they come to my office already on HRT, I'm going to do the HuMap before we adjust their levels so that I can see what their body is doing with those hormones. Okay. Pregnancy, postpartum fertility workup, really, really important because the adrenals, you can do a lot with the adrenals, even, gestationally, even perinatally and postnatally. So I have a brand new fertility protocol that I just published. Normally, I charge $95 for my protocols and guides, but if you email us, if you go to drbrandonlundell.com or nutritionalpathology.com and you email us and ask for the fertility guide. It gives you the testing that you want to do and how to interpret them. It gives you the supplement guide and diet guide. It's one of my fortes. It's one of the things I'm most passionate about, and I want more practitioners to do it. So if you're interested more in fertility workup and preconception as well as perinatally and postnatally support, then email us or just go through our contact form, and we'll be happy to give you the fertility guide. So, and we have both male and female. So, because all of you are doctors' data customers, we'll do both. We'll do the male and the female guides, which is almost a $200 value. So I'm happy to do that. I'm going to skip the HPA axis deep dive. That was kind of beyond the scope of this anyway, but I wanted to include it because I have the slides and it's in your notes, what the 4-point cortisol curve is. What I will say about it is that the diurnal slope, a flatter slope, predicts mortality across all-cause mortality across multiple cohort studies, independently of the total cortisol load. So that blunted morning, or even worse, the reverse high morning cortisol. If you have a higher morning or a higher nighttime cortisol, that's the most associated with all-cause mortality, especially breast cancer. That high nighttime cortisol, low morning cortisol, that's a real, harbinger. That's a real red flag for you to address. Okay, so another clinical pearl to not forget. Cortisol awakening response. I don't use this in all of my patients, but I do when anyone is suffering from metabolic disorders, okay, and from depression or anxiety. So that's the cortisol awakening response. All right, so I'm going to go through and start the case study here. Here's your elevated nighttime cortisol, very dangerous. So you want to use phosphatidylserine, and I use sleep tides as well. I use some sleep peptides to help lower that cortisol response. Adaptogens, rhodiola, ginseng, DHEA, pregnenolone. I use pregnenolone more than most because I've been using it for decades safely, and it doesn't seem to increase dangerous estrogens or it doesn't increase testosterone too much, but it helps feed the mineralocorticoids. It doesn't increase normal cortisol levels, okay? Just giving pregnenolone doesn't increase normal cortisol levels. It will only increase low cortisol levels. So really important about that. Gut gonadal axis. I did a lecture for biotics research, and you can also go to my website. I did a 2-part male hormone series just recently. So you can go to biotics research website, and you can watch it there, or you can go to my website and watch it there as well. A 2-part male hormone where I really go into the gut gonadal axis and the androbolome and estrobolome. So there we go. Okay, and then the PMOS is what they're calling it now, polyendocrine metabolic ovarian syndrome, because a lot of people with PCOS don't have actual cysts on their ovaries. So, okay, here's a case study that we'll go through pretty quickly because I really only want to show you, most importantly, the difference between the blood levels and the saliva levels and why people are overtreated. So this is a 49-year-old perimenopausal female, and she's kind of skipping periods and stuff. Chief complaints: profound fatigue, overweight, insulin resistance. She had been on HRT for 5 years. Guess what? All of these got worse because hormones, if dosed incorrectly, can make most of your symptoms worse. Okay, this is what she was on: 2 milligrams of estradiol, 100 to 300 cycling progesterone. 100 in your follicular phase, and then 300 for a week in your luteal phase, which is what some people try to do, but it's really wasn't helpful for her. So So she wanted to just get better. This is some of her. She had metabolic syndrome, elevated liver enzymes. Giving HRT to someone with fatty liver is like adding fuel to a fire. It's like adding gunpowder to a bomb. They cannot metabolize it correctly. So just a little clinical pearl there. I would never do, I would hold off on HRT until we got the fatty liver under control. Fatty liver is pretty easy to treat from a functional medicine standpoint. Heal the microbiome and leaky gut, and alpha lipoic acid and quercetin and grapeseed extract and antioxidants, N-acetylcysteine, very easy to treat. So I also have a fatty liver protocol. It's not a whole guide. It's just kind of the supplements I use. So if you're interested in my fatty liver protocol, give us, go through my website, email us, and I'm happy to give you that as well. Just a quick thing about thyroid. Thyroid is fine looking at it in the blood because it's a water-soluble hormone. It is not a fat-soluble hormone. So she had your classic CRP. I'll save thyroid for another time, but I've got my opinions about thyroid. What I will say there is porcine. Okay, so NP thyroid, that's so popular, and Armor. What I will tell you real quick, this is a huge clinical pearl, and I can drop the mic now, and it will make you a hero to your patient. So pay attention. Porcine, NP thyroid, and Armor thyroid, those are a ratio of T4 to T3 of 4-1. That's what most mammals produce. Humans produces T4 to T3 at a ratio of about 12-1. What that means is that everyone on NP thyroid is getting far more T3 than they actually need. So I've developed a system where we add just a little bit of levothyroxine to the NP thyroid to balance that out. And in 99% of cases, thyroid levels level out beautifully. And that's assuming you can't address it and get people off the thyroid hormones using functional medicine, which of course we do for a lot of people as well. So Allie had a lot of these inflammatory markers, and starting to go down. She was seeing another practitioner who increased her hormones. One of the things that I like to assess always, I think it's almost impossible to heal a leaky gut without removing the IgG food sensitivities. I know it's controversial, but I've done it for decades, and whenever I skip it, they almost never get better. So she was eating a lot of dairy, and she was eating other things that weren't high on here too. But dairy was one of the biggest things that was triggering her leaky gut and inflammation, and she some other things that were high as well, and gluten was pretty high. So this really does help us say, hey, the highest ones you need to remove in order to heal the leaky gut. So and the GI 360 showed significant dysbiosis. I love quoting the studies, and we should be done here in just a couple minutes. I love quoting the studies where fecal transplants balance out hormones. Well, one, we know that it reduces obesity and almost eliminates insulin resistance and diabetes. But the new studies that are showing fecal transplants, supporting menopause and fertility, it's incredible. Now, I'm not a proponent of just doing FMT, although there are some FMT in pills now, which seem to have pretty good benefits as well. If you go to humanmicrobiome.org, I think you can get some poop pills that are in clinical trials, phase 3 clinical trials. So for other things other than C. diff. But it's the point. The point is that addressing the microbiome has system-wide dramatic effects, especially on the endocrine system. So I never treat a hormone system without treating the gastrointestinal system, because that's one of the main drivers of all endocrine disruption. And you can see with her, she had a lot of proteobacteria. She had a lot of gram-negative bacteria. Her LPSs were through the roof. Akkermansia was okay, which is a good prognostic indicator. But a lot of beta-glucuronidase, a lot of LPSs, that drives estrogen excess. And that's in addition to her HRT. So really not a good setup. And I can't believe how many practitioners don't address the microbiome with HRT. And you can see here her yeast was elevated, and that's devastating. Yeast is devastating for organic acids in the mitochondria and the adrenal glands and the HPA axis. So that's, her lysozyme was elevated. Remember, lysozyme is pretty much a pathognomonic test. It's almost in most cases a pathognomonic test for leaky gut, because you can't have gut inflammation without some level of intestinal permeability and dysbiosis. So you can have leaky gut without elevated lysozyme, but you can't have elevated lysozyme without leaky gut. Okay. So we did the ion panel as well. Her glutathione was non-existent. Ding, ding, ding. That is one of the main points of endocrine disruption. And you can see her lipid peroxides and her 8-hydroxy-2-deoxyguanosine, which is an oxidative stress marker, were also elevated outside of the optimal ranges. So let's see, we did, some other, her, tyrosine was elevated, a lot of B6 deficiencies. That's another clinical pearl to write down. B6 deficiencies drive imbalances in hormone metabolism, because B6 is needed for almost all of the methylation enzymes. And a lot of practitioners forget about the B6. When you have high tyrosine, tryptophan, glutamic acid, that's almost always a B6 deficiency, because the decarboxylase enzyme needs B6. So organic acids is really important. And I do go into that, and I teach you how to do organic acids in my classes. So you can sign up for my classes and we can go more into that. Okay. Her choline was low. I'll just show you here. Her choline was really low. When choline is low on the SpectraCell micronutrient test, that almost always tells you there's a methylation deficiency. Okay. And here we can see that she was making enough SAMe, which is rare but good, but her transsulfuration was not good. She didn't have enough transsulfuration. So needing more methionine, she wasn't able to process cysteine. That is a B6 deficiency. So she was taking B12, but it was imbalanced. She wasn't taking a B6 and other B vitamins as well. So here, what is her blood levels were normal if you look back at the blood levels at the beginning, but here's what her testosterone level was in the saliva test. The healthy range for a perimenopausal female, in my opinion, should be around a 10 to a 30. Even in the 40s, in my opinion, is too high for a postmenopausal female. It usually means there's some PCOS or something, or PMOS going on. She was being treated, look at that, 235, and her practitioner said, like they always do, we should probably increase it because we want to help you lose weight. We want to increase your metabolism. We want to increase your lean muscle mass. That's not the way to do it. And so every single time now, even the supplemental range is 25 to 60, and she, let's say you're supplementing, still shouldn't be in the more than the 40s. So she was 8 times higher than what, even 10 times if you think 23 would be a good level. So really not very good at all. And this is her salivary cortisol. She was stressed in the morning, which allowed her morning cortisol to be normal, but then the rest of the day was flat. And she had a little bit of the rise in the nighttime cortisol, but thank God she didn't have that, because that's even worse. Sure enough, she had low melatonin, so that's going to be an important point. So that's basically what we did. We looked at the insulin resistance. We treated the adrenal insufficiency for the rest of the day. Here's what we did: the anti-inflammatory diet, the 4R protocol with some Saccharomyces, probiotics, glutamine, all of those things, butyric acid, because her butyrate was low in the GI 360. Broad spectrum methylation support, not just the methyl B12. antioxidant supports, mitochondrial support, and we started tapering off. And we added sleep tides. For the sleep tides is nice because it's an orexin inhibitor, so that really helps the adrenals repair at night. So that's something that I use a lot. And we did phosphatidylserine as well. We looked at her thyroid, and this is just what I was saying earlier about why porcine nature thyroid is not enough. You got to add levo to that. So we started seeing her CRP come down, and her hormone levels start to balance. Her insulin levels are starting to decrease, because at one point it was 30 something, and it's coming down. And we actually followed up with the HuMap a couple months later, just because of timing for her. And we already started, she was a few months into treatment, and we already started to see a normalization of her cortisol awakening response. We started to see more normal cortisone levels and estrogen levels, still imbalanced 4 and 16 hydroxy. So we wanted to add more DIM and grapeseed extract and milk thistle and N-acetylcysteine for that liver support. But her 8-hydroxy 2-deoxyguanosine decreased, so it's much, much better than it was even just a couple months into it. So there you go. Her testosterone levels started to normalize. It was at 73, and that was about just a few months into kind of decreasing it. But it takes months for those adipose stores, especially since she was overweight. It takes months. So she was completely discontinued by this time. And she had discontinued it in November. So she's almost 6 months from discontinuation, and she still has high levels of testosterone 6 months later. All right. So I think I drove home that point enough. So her curve looks much better. Almost everything is within normal ranges. And she's able to have higher levels during the day. Her CRP continues to go down. C-peptide continues to go down. It was 10 at one point. So that's the power of this functional medicine approach. So remember, use the right test for the right patient and the right question. Are you looking at production? Are you looking at tissue levels? Always assess the HPA axis before doing HRT, especially for parenteral HRT. Serum is blind, okay? Serum is, well, not entirely blind, but serum is inappropriate. So, and combine the media. Saliva plus HuMap for body burden gives you the full clinical picture. So here's all my references. I don't know if there's time for questions. What I do want to do is just, again, a good doctor knows what to do. A great doctor knows why. If you're interested in learning more of how to do not just HRT, but all the functional medicine in a scientific, proven way, not only do we use evidence-based research, but I'm in the trenches and still see patients every day. So nutritionalpathology.com. You can look at my courses. One of the most popular is a mentorship course. So I have courses that you can take. That's like seminar, webinar style courses. Mentorship is where you get one-on-one with me we have a small group setting. I usually limit it to just 14, 15 docs. And then you get one-on-one with me, just you and I, going through cases, going through whatever you want to talk about that's holding you up. And that is extremely popular. I love doing it. It really gets in 6 months. It's a 6-month mentorship. And in 6 months, you can save years and years of trial and error and trying to figure out how to implement it. Because really, isn't that the main thing that's missing? We don't have a residency program. We don't have a mentorship or an apprenticeship program in functional medicine. And that's the need that I want to fill. So Doctors Data sponsors it. You actually get 2 free tests with Doctors Data. You get a HuMap and a stool test, the GI 360. That's worth almost $800 retail right there. And I go over those with you and how to interpret it in the small group classes. You have LabCore, some free tests from LabCore. You have some discounted tests from US Biotech, like organic acids. So you get almost $2,000 of free tests and products. Biotics Research is a huge sponsor. You get 15% off products throughout the whole course, throughout 6 months. So that can save you thousands of dollars depending on how much you order. And it is one of the most affordable training programs out there if you compare it to all the ones, whether it's, well, I don't want to say their names because I don't want to promote them, but I'm by far the most cost effective. So, because I want this to be available for people. So thank you again to Doctor's Data. You can email us, go to nutritionalpathology.com, go to drbrandonlundell.com. And I do have some questions that were loaded up from before, but it's already 2:15. Angie, what do you want to do? Do you want me to just answer these through an email, or is there a couple that are came through during the webinar here that you want me to answer?